So good afternoon, everyone, and welcome to Medical Grand Rounds. Before I introduce our speaker, just a reminder to please enter your questions in the chat at the end of the presentation. And I would ask you to please answer a brief survey that will be sent to you immediately after the presentation, and this will let us know that you were present at today's rounds. So I would like to introduce our speaker. It's a great honor to have with us today Dr. Michael Goldfarb, who is a colleague of mine from the Jewish General Hospital. He is an early career critical care cardiologist and a clinician investigator at the JGH and the MUHC. He trained in internal medicine, cardiology, and experimental medicine at McGill, followed by critical care training at Cedars-Sinai Medical Center in Los Angeles. He has authored more than 40 peer-reviewed publications, including publications in top cardiology and critical care journals, and he's a frequent presenter at national and international conferences. Dr. Goldfarb's research program is focused on improving outcomes in older adults with acute cardiovascular disease and engaging families in care. Dr. Goldfarb is the recipient of the FRQS Chercheur Boursier Junior 1 Award. Without further ado, I'd like to give the floor to Dr. Goldfarb. Michael, thank you very much for joining us today.
Thank you so much for inviting me. I'm looking forward to speaking about this topic that's become increasingly more interesting to me. It's part of my larger EPIC program, which is engaging patients and family in care. But today, obviously, we're going to focus more on the family aspect. It's something as a clinician that I've always noticed, I've always been concerned of how we engage with family members, but it was only during my fellowship in critical care did I kind of sit down and take a look at it and realize that it's an area that's probably underserviced in a lot of ways, and we'll talk about kind of the evidence in this area. So I have no disclosures to declare in respect to this presentation. So these are the broad objectives, but as you'll see, we'll talk about some other things as well as we go along. So number one is to highlight the importance of family engagement, and right here in cardiovascular care, but really this is universal, and it refers to all kind of aspects of healthcare. I'm going to hone in and specifically talk about cardiovascular care, but also mention other aspects such as intensive care, unit care, as well as other types of ambulatory care as well. And we're going to describe some of the benefits of family engagement in care. Where's the evidence? That's something that's very important to me as a clinician. And describe some opportunities to engage families in care, and as well as throughout, and at the end, I would like to hear your opinion, how you engage in care, families in care, and where you see opportunities for engagement of families in care. So please feel free to write comments in the chat as we go along, and if I don't see them, we can discuss them at the end. We'll start with a case. So we have an 82-year-old woman. She's admitted to the cardiac ICU for an acute MI, an NSTEMI, on a Friday afternoon. Now, this is actually a real case, but it's based on a few different people, which I amalgamated into one, just for a dramatic effect. Her past medical history is hypertension, dyslipidemia, and some mild cognitive impairment. She does live alone at home. She does her activities daily living by herself, and she does get some help with her IADLs from her daughter. She arrives on a Friday afternoon. The daughter wants to stay, but at the time, the rule in the unit where she's in is the daughter cannot stay overnight, only during visitor hours. The patient spends most of her night awake, but not particularly agitated, and so then the nurses kind of leave her alone. The following morning, the team comes to see her. The daughter's not there because she couldn't enter the cardiac ICU until 9 a.m., which was the policy at the time. The team sees her before. The team comes up with a medical plan to do a coronary angiogram on the first weekday, Monday. The team discuss it with the patient. The patient doesn't seem to be completely understanding what's going on, but nods her head in agreement. The daughter comes after the rounds, asks to speak with the medical team. The resident happily comes and updates the daughter on the situation. And the daughter does tell her that I think my mother's a little bit confused. The following day, the team sees her again. The plan is still to cath her the following day. The mother's still slightly confused, and the daughter is kind of given some educational information about the coronary angiogram and agrees with it. The following day, an angiogram is performed, finding complex coronary disease with multiple options. medical revascularization with percutaneous intervention, PCI, or cardiac surgery. And there's a discussion with what we call the heart team. Following day, the patient is presented with the options. The daughter is there as well. The team discusses with her. After a discussion with some other family members, they elect to do a multi-vessel, a PCI, due to the concern of worsening cognitive impact in the postoperative period and other kind of recovery issues. The following day, while waiting for the intervention, the patient has chest pain, becomes hypotensive, altered mental status. The patient is in shock. She's given emergency care, intubated, balloon pump placed, vasoactive medication started, and she undergoes emergent multi-vessel PCI. The daughter is contacted and comes in a state of emergency. Over the next few days, the mother does better. Her shock gets better. The medications are slowly stopped, and she's extubated. Because of the intubation, it's kind of difficult for the patient to eat. The daughter helps out by helping feeding her mother. The nurse notes that the patient is quite deconditioned. She'll see a physiotherapist. The daughter's concerned her mother won't be safe at home, at least for a while. So they decide to increase physiotherapy and eventually apply for cardiac rehab. The physiotherapist sees the patient, but is limited by time and availability. And eventually the patient goes to rehab with the daughter coming and visiting. So let's talk a little bit about this family experience. So for a family member, particularly when the patient is quite sick, it's quite stressful. There's noise, lights, the physical environment. They're constantly subjected to medical jargon, despite the best abilities of the medical treating team to kind of put it into lay terms. There's a lot of treatment decisions that have to be made, often life or death. The family member is subjected to sleep deprivation and disruption of their daily routine. The family member may have other responsibilities. They may be a member of the so-called sandwich generation and have to care for kids at home and an elderly parent in the hospital, or a spouse, and can't go to. They may have to work full time at the same time. Their family members in the hospital, so their family routine, their daily routine can often be quite disrupted. And this whole experience leads to what's called shock and disorientation. And as a result, up to half of family members of intensive care units experience psychological symptoms during and following hospitalization that can last for quite some time, such as depression, anxiety, and post-traumatic stress. So this concept of patient-centered care, we're going to back up a little and just talk about this term, which is a buzzword. But where did it start? Well, it was first gained popularity, the idea of patient-centered care, about 20 years ago, when the Institute of Medicine published their seminal report, Crossing the Quality Chasm. The family-centered care kind of gained prominence 6 years after that, when in the critical care literature, this professional society kind of supported the ideas that we need to arrange care towards our family members as well. And then the Institute for Healthcare Improvement also kind of popularized with their report in 2011, talking about this whole concept of how we should approach medicine as a different way of healthcare delivery as patient and family-centered care. And since that time, these ideas and these terms have kind of taken off. And we'll go a little bit further into the term in a moment. But patient and family-centered care is often confused with other terms, such as engagement, activation, and they are related terms, but they're different. And we'll make them quite clear in your mind in one moment. So let's look at this paradigm. So you see that the patient and family live in the community. They're influenced by their social determinants, their cultural experiences, ethnic background, and their lived experiences. When they then encounter the clinical system, the clinical care system, they have interaction with healthcare providers, and the acuity and condition of their medical condition affects how they are. And given the right conditions, given the right ingredients, we'll discuss what they are in a moment, the result could be patient and family-centered care, which can be measured by both clinical outcomes as well as patient and family-centered outcomes. We'll define what those are in a moment. So this term activation. Activation refers to the internal skills, confidence, and knowledge of a patient or family member. And as you can see, it's informed by who they are as a person and their prior experiences, where they come from, as well as their interactions with the healthcare system. Coupled with opportunity, the result is engagement. Engagement is the behavior or their actions that they take in order to achieve patient and family-centered care. Obviously, this has to be done in a system that supports partnership and it treats patients and family members with dignity and respect. And as a result, outcomes can be measured, which could reflect the patient and family-centered care delivered. So as I mentioned, activation is the internal capacity of the person, the knowledge, skills, and confidence that they come with, as well as that they acquire during the hospitalization. As well, and then coupled with opportunity, this results in engagement in care, which is the behaviors they exhibit, and resulting in patient and family-centered care. So why should we engage in care? Well, number one, it improves the care experience. There's evidence that improves the care experience and better outcomes for patients, family members, the healthcare providers themselves, and the healthcare system. And family engagement, as I just showed you a moment ago, is actually the how to achieve patient and family-centered care. It's the operational arm, which means it's what we do, the behaviors, the activities that allow us to achieve this patient and family-centered care. Now, when I say family, I mean family in the broadest sense. It's anyone with a biological, emotional, or other kind of connection with the patient, and the patient wants them to be involved in the care. Often this can be determined prior to hospitalization with a surrogate decision maker or a mandate, but often it's someone who comes at the hospital or is involved by phone or virtually at the time when the person needs assistance at the time of hospitalization. And it's not one size fits all. The patients and family can choose if, when, and how much, or how little they want to be involved in care. Some not at all, some want to be involved a lot. But there's a lot of evidence that patients want family involved. Now, this is a recent survey done for patients following up their hospitalization at acute cardiac units at the MUHC. And it found that only 42% of patients following hospitalization felt that their family members were involved in care and treatment decisions as much as they wanted. And this is one of the lowest rated patient-centered satisfaction scores in the whole survey. Family members also want to be involved in care. Now, a lot of this is due to changes in societal influences. This is one study, a little bit older, but it did show that in many ICUs in France, they interviewed a number of family members, and that 88% of family members felt that participation in care should be offered. I imagine the numbers are similar or higher now, 18 years later after the study was done, 19 years later. And as a result, these international bodies and governmental agencies strongly recommend family engagement be integrated into healthcare delivery. Organizations such as the World Health Organization, Accreditation Canada, and in the US, agencies for healthcare research and quality all strongly recommend family engagement in care. Professional society and patient and family advocacy groups as well strongly lobby for family engagement in care. Excuse me. Critical care societies kind of led the way, the whole way, and they include F as family engagement, empowerment as part of their liberation bundle. Medicine joined solely after, and as soon to be released cardiology guidelines strongly recommending family engagement in care, as well as nursing, primary care, and other advocacy groups as well strongly supporting family engagement in care as a recommended healthcare delivery practice. And why is that? The family member has a quite important role. Their family member is a valuable resource. Caregivers may range from, may come to the hospital to visit. They can help support their family member through an acute illness, coordinate ambulatory care, transportation to medical visits, provide emotional support, medication management, communication, decision-making. They can be extenders of the healthcare team. They can provide instrumental care and assist with basic activities. They can do a lot of things to help that patient through their healthcare journey. So how do we conceptualize this? So Carmen and colleagues came up with this different levels of family engagement, and there's three kind of main levels here: is the direct care, organizational design and guidance. Let me just put on a pointer if I can. There we go. Direct care, organizational design, governance, and policy making. Today we're going to focus mostly on this first level, the direct care level. But just to keep in mind, the subject is much broader and involves other levels as well. Within this direct kind of care contribution, Oldring came up with these different categories, and they range from the most passive, being presence, family presence, being there, to the most active, which is directly contributing to care. And in between, you have other levels where family members can be involved in care. So one is the family members themselves receiving care and having their needs met. The family member can receive information and communication, which they can then use to help the family member make decisions, and as well as participate in decision-making process, either as a substitute decision maker or a part of the shared decision-making process with the patient. And within these categories, there's a number of opportunities. Now, there's many more than this. This is from a paper looking specifically at some of the things that may be applicable to cardiac ICU care, but it could be in many other settings as well. So under family presence, we have opportunities such as visitation policies. Are they open, flexible? Do we let the patients come in, or family members rather, come in whenever they want, or during many more hours during the day? Or we allow them to stay present while we're resuscitating their family members? You know, classically, I was taught, you know, as soon as resuscitation, ask the family member, go wait in the family room and we'll come let you know after the result. During invasive procedures, can they stay while a resident is putting in a central line, while other kind of bedside procedures are going along? Can they stay in the room? Can they participate during team rounds, either just being physically present or actually participating in the team rounds? And as well as help personalizing a patient's role. In terms of getting their family, their own needs met, we talked about the psychological issues they go through and the stress, the physical stress as well. So there's other opportunities such as the physical environment, sleep, noise, and light, getting support either by a dedicated support specialist or a spiritual support, documenting their own kind of psychological turmoil or their own thoughts in the ICU diary. As well as there's ways to communicate with the family with structured communication tools, having conferences to discuss what are the active issues, being informed with information, participate in the decision-making process, or directly contributing to care, such as basic care, such as feeding, bathing, helping with mobilization when detecting delirium. So as a clinician, I want to know, do these engagement strategies actually live to improve outcomes? So during my critical care fellowship, I looked at that question and I wanted to look at the literature. So I reviewed the literature for patient and family interventions that included patient and family outcomes. And we found 11 randomized studies, and the majority of these reported some type of outcome measure. And as you can see by the type of interventions that were used, there are many different types of interventions that were used to try to achieve improved patient and family-centered outcomes. So we'll go over some of the interesting ones. So in terms of family presence, there's been some studies that looking at different visitation policies. One of the concerns with allowing visitors to come in, particularly during the beginning stages of COVID, was that would lead to more infection rates, such as nosocomial infections or spread of disease. At least in this study, it showed that allowing family members to visit up to 24 hours a day versus restrictive visiting during certain hours improved psychological outcomes in family members and didn't change the infection rates or lead to increased healthcare provider burnout. The study was mostly looking at nurses who had the majority of interactions with family members. Interesting to note is 24 hours a day does not mean 24 hours a day. Family members in the studies generally only stayed 3 or 4 hours a day on average, compared to 1 or 2 in the restrictive visit policies. So just because you open the door doesn't mean that patients will, or family members rather, will stay there all the time. How about the changing of the approach to allowing family members witness resuscitation events? Well, this is a systematic, there have been a number of randomized trials and a couple of systematic reviews, and they show that overall, you look at the family member after the event up to 1 year, and there's lower rates of psychological outcomes in family members who are able to stay and witness the event. Of note, many family members declined, not the majority, but the minority of family members declined to stay present when offered. So keep in mind, family members may not want to stay present, but if they do, there is some evidence that it does not impact the resuscitation characteristics, does not increase stress on those providing the resuscitation efforts, doesn't impact whether the patient survives or not, whether the family member is there or not, but it does improve psychological outcomes in the family members. As well as family presence during team rounds. One of the concerns here is that it will actually impede the instruction of family members, of residents and house staff during rounds. And there's been no evidence so far in the studies that it impedes teaching of house staff. But it has been shown there's improved communication with families. It actually can reduce rounding time because you don't have to later kind of get stopped and discuss with family members what's going on. And it can improve provider satisfaction. From my personal experience, I've been trying to invite family members to participate in my last little while in my rounds. And I find that even when family members don't, first of all, sometimes they actually contribute information that's quite important that can help you understand where their loved one, where the patient comes from, and can actually help with some decision making. But it also allows them to see how hard the team is trying. So it's one thing to see the team talking outside the room. It's another thing if they see the active effort that the team is doing and the systematic structured effort the team is doing in assessing their loved one. Of course, there's issues of confidentiality and other things like that that must be maintained because you're discussing other patients sometimes at the same time as you're rounding maybe on one patient with a family member present. So that also has to be ensured. There's also studies that look at information. So this is a randomized trial in 175 family members across France, and it found that giving family members information leaflets improves their comprehension and leads to better satisfaction. So just something as simple as giving them information leaflets helps put their mind at ease a little bit because they understand a little bit what's going on. As well as communication strategies can also have an impact. This is a study that looked at very, very sick patients, end-of-life care with a high predicted mortality and a surrogate decision-maker present. And it found that family members had decreased depressed symptoms, although there was no difference in anxiety or PTSD symptoms. There's no changes in mortality. But as most of these studies show, when you communicate better, it decreases length of stay and decreases ICU costs, many of the times because it's decision to withdrawal of care earlier in accordance with the patient's pre-stated wishes or the family member's wishes. So overall, my systematic review of meta-analysis from a few years ago showed that the interventions to improve patient and family-centered outcomes were associated with improved patient experience, family satisfaction, medical goal achievement, psychological symptoms, and ICU costs. Since then, a number of studies have emerged. I participate in this one as well, a systematic review and meta-analysis of surrogate decision-making. So that we found a whole bunch of RCTs, and we found different types of interventions that were done. The main findings were that the ICU length of stay was shorter amongst patients who died. So if having a surrogate decision maker involved kind of helped us make decision not to be aggressive earlier and decrease length of ICU stays by 2 days, which is significant. And not surprisingly, there was some evidence that there were some reduced costs as well. This study did not find there was any change in satisfaction or psychological comorbidities or perceived quality of care in family members. So some different results in different studies, no negative results, but a lot of either no differences or some benefits. Just a note about caring for the caregiver. We talked about family needs, and this is something that it seems a little bit counterintuitive because you're talking about treating your patient in front of you, and all of a sudden we're talking about treating your family member and caring about the outcomes, about psychological outcomes and health outcomes of the family member. This is, I think, important. I think it is the family members' outcomes are important during hospitalization and their psychological and physical, but I think it's also important kind of outside the hospital in ambulatory outpatient care as well, and I'll explain why. The patient's illnesses actually affect the health of caregivers. The caregivers themselves are more likely to be, on a whole, on average, more risk for obese, lower physical activity, and less healthy dietary behaviors. There's many psychosocial stresses that could be on family members. If they have some inherent cognitive impairment, the patient, that is, the stress of the caregiver is often magnified. And the majority of these caregivers in cardiovascular disease have been shown to be older, and many of them happen to be women. So I decided to do a study to try to improve the health of family caregivers. So just a few notes about these family caregivers. As you mentioned, they are at higher risk themselves of cardiovascular disease. And the family members often have a higher risk of modifiable cardiovascular risk factors. But interestingly, at the time of the family member's hospitalization in the cardiac ICU, let's say a family member, the patient has a heart attack, the family members are often very willing to participate in their own healthcare, their own screening. It's an opportune time to intervene. And patients are very willing to refer their family members for their family member healthcare screening at that time. The family members are highly willing to participate. So we did a study. So what we did is we took people that were hospitalized, probands. You can see here 146. We asked them, do you have any family members who might benefit from cardiovascular screening? We enrolled 84 of them. Ultimately, we got 51 of the 84 to enroll family members. Number of family members couldn't be enrolled because of distance to study center, or there wasn't an appropriate family member. And we screened them. And we got 101 family members. And after 6 months, we've retained only 54. So you can see there was a number of dropout between 1 and 6 months, but I'll show you what we found. We found that family members at initial screening had 45% of them had an intermediate or high risk of modified Framingham risk score. In fact, the mean risk was 13.6%, so being 10 and 20% being intermediate risk. And what we found was 1/3 of family members had a new diagnosis, so unknown, unpreviously diagnosed hypertension, diabetes, or dyslipidemia. And multiple of them had 2 cardiovascular risk factors, and one of them had 3. So very interesting that we found. In fact, look how many, it was shocking to me is how many new cases of diabetes we were able to diagnose. And when the ones who actually completed the follow-up, we had about 60% who completed the follow-up, the mean modified 10-year Framingham risk score decreased by an absolute value of 4.6%. And when we take out the patients who were initially on statins at the initial visit, there was still a quite impressive decrease of 4.3% in the modified 10-year Framingham risk score. So there is a role for identifying and treating the family needs or the physical needs of family members after the family member is hospitalized. This is one study to support that idea. How about when the family member is hospitalized? How else can they engage in care? Well, this is a study looking at family-guided mobilization. So this is we did a survey on family members, and we asked them, how much would you like to help mobilize your family member or friend? The majority of them strongly agreed, and the rest of them agreed with it. So this is a small study, but shows that the majority of people likely want to be involved with assisting their family member with mobilizing. Then this is we asked them the question, are you sure when it'd be safe to mobilize your family member? So we actually gave them instruction on mobilizing. So it's a double negative, but it turns into a positive, I guess. So I am not sure, this is a statement, I am not sure when it would be safe to mobilize my family member or friend. And the majority of them disagreed. Well, some of them still agreed after receiving instruction. So this suggests that once you give them instruction on how to mobilize, they are a little bit more confident on how to mobilize their family. And we actually tested it out. So we developed at the Jewish General Hospital, and is actually also implemented at the Royal Victoria Hospital, a nurse-driven, family member engaged early mobilization program in an academic tertiary care cardiac ICU. That's the Jewish General Hospital. So how it worked was the nurse would do an initial functional assessment on the family member, assign them a level of function, which would be between 0 and 5, as you can see on the right, 5 being able to walk more than 20 meters, 0 is essentially they can't move out of bed, and then functional status in between. And based on that functional level, they were assigned 3 activities. And they were assigned these 3 activities twice a day, so up to 6 activities a day. While the nurse would assign the activities, the patient and family member themselves could perform the activities. We provided videos, which are available on a smartphone or computer or whatever, where the family members could watch these videos by the bedside, and then based on the current level of function of their family member who is hospitalized, they can then do these activities with them. So this is a review of 15 months of data of this program. We looked at 852 patients, and they come in with the usual cardiac diagnoses, the majority of them being acute coronary syndromes, heart failure, and atrial fibrillation. And we see what is prior to hospitals, or their functional status is near 5, which is normal. On admission, the time they come in, it drops to 3.3. And then the functional status increases to 4.2. Now, this is at the end of cardiac ICU discharge, not at the end of hospital discharge. We didn't record to end of hospital discharge because of challenging reasons to record, but you can see there was already a tremendous improvement and suggests that if this continued, it's possible that would be even better functional improvement at the time of hospital discharge. And we found was prior to instituting this program, this nurse-driven family engaged program, the mobilization opportunities were not very well utilized. Whereas after we started, it was near ubiquitous mobilization of family of loved ones. And 90% of those activities that we assigned were completed. And there was very few adverse events, only 15 adverse events, none major, all kind of minor expected. Most importantly, no injuries to healthcare personnel or family members, no patient falls, no tube line dislodgements. So suggesting that this nurse-driven family engaged approach was safe, feasible, and this is our outcomes table, which shows that the program itself, looking at prior to the intervention to after the intervention was implemented, the discharge, so more patients were discharged home. So about 4% absolute risk increase in likelihood to discharge home, less discharge to rehab facility, and less 30-day ER visit after discharge. Interestingly, we also found a signal to decrease in hospital death in the intervention group. I don't know if that's real or not, or some confounders there, but that's something that we're exploring in future studies. But we're suggestive that family members involved in care can do it safely. And one of the reasons this came out is because one of the reasons I discussed in the case is physiotherapists don't have the time to ambulate the family member, the people in the hospital multiple times per day, or on weekends or on holidays. The resources are not there. Nurses, likewise, also have challenging time finding the time to mobilize family members. Who's there? Who's willing? Who's motivated? Who can do it? Family members. So that was the approach we took on this, and at least the observational data seems to support it. More randomized evidence needs to be done on this topic. So I mentioned caring for the caregiver. We'll just talk about a couple other aspects. So heart failure is the best kind of study condition in cardiovascular disease because there's a really traditionally high caregiver involvement, and it's a chronic progressive disease. But when you look at heart failure caregivers, they have multiple needs unmet. They're often unprepared for managing these complex medications and devices, balancing their own home and work responsibilities, engaging in their own self-care, and handling any emergencies that arise. The resiliency is often not there. There have been a number of interventions that looked for heart function caregivers for their needs, and they've ranged from face-to-face nurse psychological educational support of patient caregiver dyads to mobile health support for self-care. But really, the evidence has shown inconsistent benefits. Some have found some reduction in caregiver burdens with these interventions, others have not. Just touch upon this 1 second. This is something that's quite important. It's something that we've all dealt with. This is a sign not from the MUHC. It says no visiting during COVID, no visitors allowed on site at this time. But I have a same picture from the MUHC. So there was a time when no family visitation was allowed, whether it was concerned initially about masks and gloves or prevention of infection spreading or whatever. There's a number of reasons. There was a strict blocking of visitors. And even when a lot of the strict visitations were pulled off, there were still some restrictions in place. For example, I'm not sure if this was the case at the MUHC, but definitely the Jewish General Hospital, there was a time then visitors were only allowed to come up after 9 a.m. So they often missed team rounding, as I mentioned kind of in the case that was presented. So what are some of the issues from the COVID-19 pandemic? So mostly the restricted visitor access in person has had a tremendous impact on their patients and families, particularly in vulnerable populations, the ones least likely able to advocate for themselves. So I include in these older populations, as well as people who don't speak the language, people there's cognitive impairment, as well as an intensive care unit kind of where the family member can advocate for themselves because they're too sick. Overall, and there's been a number of papers on this, and people advocating for a need to balance the healthcare system needs with the patient and family needs. And one of the ways that I've argued and others have argued is there needs to be more acceptance of a designated essential family member. In severe circumstances, maybe only for those who are the most vulnerable. And I think a lot of systems have adapted to include this. But the essential family member is the one. So maybe you don't allow in 10, but you allow in one, and that one person can really help. Now, of course, there'll be a lot of burden on that particular family member, and that needs to be taken into account. But this essential family member can help for all those valuable resources that we discussed before. And as well as when you can't come in, or when the family member may be sick themselves, but still wants to participate and still wants to help out and be involved in the decision-making process, we need to have better systems in place for a virtual presence and communication. I mentioned these are the special population groups which may be at risk for adverse outcomes and really need family member involvement, as those with lower socioeconomic status, underserved populations with language communication barriers, and older adults. So we'll change gears a little bit, and we talked a little bit about certain engagement measures that were in place and kind of patient and family-centered outcome measures that were in place. But how do we actually measure these things? What are the tools that we use to measure it? And we're going to talk about these three concepts we alluded to at the beginning: is activation, engagement, and patient and family-centered outcomes. So let's see how they fit into the system. So activation, as we mentioned, is the internal skills, confidence, and knowledge that a person or a patient and family member has. And we can measure that using a couple of different things. So the patient activation measure, which I'll mention in a moment, has been widely validated to look at this activation in a patient. Right now, there's currently no family activation measure. This FAM is what I'm developing, which I'll show you in a moment. Engagement measures as well. There's been a number of patient engagement measures which have been proposed, and they've all validated, and they've all been validated in kind of specific populations. So outpatient ambulatory settings or other types of settings. There's no strong family engagement measure, particularly for inpatient care, and that's what I'm developing, or we're developing rather, with this FAME measure. So how about measuring patient and family-centered outcomes? So generally, those are split into two groups, PREMs and PROMs. So the PROMs are these patient-reported outcome measures, and they consist of global health, mental health, physical health, and social health. And there have been various acronyms of measures that have been studied and validated. And then in this patient-reported experience measures, PREMs, the two major kind of domains are satisfaction experience. And likewise, there are ways of measuring this as well. I mentioned the patient activation measure. There's been a lot of work by Hibbard on this. Started as more than 13 questions, and they pared it down to 13 questions, and then 10, then 2. But it essentially, the PAM13 is kind of the most frequently used. It's been validated in many, many studies. It requires a license to use, but it's not particularly expensive. And what they do is they look to see if patients, through this level approach, so level 1, 2, 3, and 4, if they have the following domains: skills, knowledge, and confidence at various levels. The family activation measure, as I mentioned, is currently under construction. These are the 4 questions that we're piloting, and they look at these different domains: desire, knowledge, confidence, and skills. All things that are very important when trying to determine activation measure. We made it as 4 questions because we felt that 13 was a large burden on family members, and we think that we were able to capture all these domains. But like I said, it's in process. And what's important is we really want to show activation leads to engagement and leads to patient and family-centered care outcomes. How about engagement itself? So we developed this FAME study, this FAME survey. It's actually a questionnaire, not a survey. And the point is, we're trying to use it to improve the quality of care. And I'll mention how we're doing that at the MUHC in a moment. So we looked at these 5 domains that I mentioned before: presence, family needs, information or communication, decision-making, direct care, and we incorporated them into the questions. We included 2 patient family-centered care principles, and we also had a section on desired engagement activities. But the key thing really here is engagement. How can we measure engagement? And are we measuring it appropriately? So with a grant from the Department of Medicine at McGill, we launched on a quality improvement project, which is being done concurrently at the Jewish General Hospital and the McGill University Health Center. So how was our process at the McGill University Health Center? Well, one is we're going to develop a family engagement team. We're going to assess factors that influence family engagement. We're going to then select and implement a family engagement intervention. We're going to measure engagement again, see how we've changed it. And then we're going to review it. And through this continuous quality improvement cycle, we're going to keep potentially adding new interventions, measuring engagement, and seeing how we improve outcomes. So the team is a multidisciplinary team. Of course, we have patient and family partners who have already provided a tremendous amount of feedback, have the quality improvement team as well. We're going to measure engagement on a number of levels. We're going to measure healthcare provider engagement through this validated survey, the questionnaire, the Q5 survey. We're going to use our FAME questionnaire to find out how families feel about engagement, and as well as a patient engagement measure. We're going to measure, we're going to select an intervention that we feel is feasible and can improve engagement. We're going to implement it. We're going to measure it again with these measures that we've done, see how they're responsive to change, and then review. So these are the people who we are putting together for our QI task force or team. As you can see, it's a whole group of disciplines working together to share a common goal. These are we're going to do a baseline assessment. These are the different measures, which I've mentioned already. We're going to choose an opportunity. I mentioned a whole bunch of opportunities that we have to engage in care, and we're going to see what we think is feasible and implement it. We're going to measure it again, see how we've done, and then we're going to choose some outcomes that we want to measure and report them, and go through this continuous QI cycle and improve the process and potentially implement new interventions. So where do we go from here? I think that the process of family engagement is not very well taught. Not only do I think that, I've reviewed the cardiology and medicine kind of principles for family engagement, and they're lacking. They give lip service to incorporate family members in decision making in one or two other kind of areas. But there's a strong need to incorporate principles of family engagement training, perhaps modules, perhaps simulation, medical simulation. There's lots of opportunities for someone in medical education to work with. How about research? We need validated measures. That's something that I'm working on. We really need to assess the impact of family engagement on clinical outcomes, which means if you improve engagement, do you improve patient and family-centered care? We need professional societies and their conferences and to have advocacy to increase family engagement and care, as it's starting to do already. Like I told you, in cardiovascular care, with the American Heart Association releasing their statement shortly. We need to promote family engagement in the greater society. Work with community-based advocacy groups, promote the idea that family members are active participants in care. And this is something in the last 5 years has kind of accelerated. As well as we need to harness health technology, whether it's telehealth, communication tools, artificial intelligence. There's many opportunities to engage family members in care. So now that we've gone through that presentation, you're going to put on your family engagement glasses, and we're going to look through our case stem and see where could we have engaged the family member in care, or where did we engage the family in care. So when the daughter wanted to stay and wasn't allowed, is our visitation policy up to date? Could we make certain exceptions? Because I think one of the things that was happening here is that the family member, the patient was awake at night and probably quietly delirious. But because it wasn't agitated, it wasn't helped with a medication potentially to help with the delirium. Family members may be able to participate in rounds, give valuable information over that the family member, and maybe making decisions in consent as a surrogate decision maker at that moment, as well as communication. It seems there was communication done here, making sure that communication is done on a regular basis in a structured way. Delirium detection. There has been more and more evidence. I didn't go through it, but there's actually a lot of strong evidence in RCTs showing that family members are very good at detecting delirium, not surprisingly. And there is something called the family confusion assessment method, where the family members are able to use this tool to assess delirium in their family members. And they are better able to pick up the quiet delirium rather than the agitated delirium that the healthcare workers are usually better at picking up. As well as there was a space here for education information when daughter received educational information. After, when the team was together, the daughter and the patient were involved with shared decision making, which was great. And then there was the shock and awe, shock and disorientation, as we called it before, is the family was in the family member was in quite psychological turmoil when she came in. And there's a strong need to really consider her family members, her needs at that time, psychological and physical, have space available, and communicate kind of the situation and see if that family member needs support. And then there's the direct care contribution. So the daughter helping in feeding the family member, the patient. The daughter did not have an opportunity at this time to kind of mobilize the patient. Maybe if the daughter had better instruction and mobilization or a mobilization program in place, may be able to help out better. And the daughter also plays a very important role in the care transition process. So that's another very important aspect of family can be engaged in care. So in summary, you have an activated family member, which you can contribute to through some clinical support. You can provide them the opportunity, and then that results in engagement. And as a result, you have patient and family-centered care, and hopefully improve the patient and family-centered care outcomes, and potentially clinical and resource outcomes, such as length of stay and other outcomes as well. And it's really key. Engaging patients and families as partners is a paradigm shift in care. Paradigm shift is a buzzword, but it really is. We're by creating this active partnership where patients and family members are essential parts of care delivery, you're actually going to improve their care, hopefully prevent burnout, although there's a need for studies to show how much it impacts caregivers, the engagement in care, but it really is a paradigm shift in how we provide care. Remember, most patients and families want it, but we really need to define how much they want it and respect it when they don't want to be engaged in care. There's a growing body of supportive evidence, but more is needed, as always, and really healthcare professionals need more education and training. I want to thank FRQS, who supports my research, the Quality and Outcomes Research Fund at the Azrieli Heart Center at the Jewish General Hospital, which has supported some of these studies, as well as, as I mentioned, the QI Award for the McGill Department of Medicine. Hopefully more good quality improvement stuff coming out in the future. So this is a survey. This is open to you, healthcare professionals of various means. So feel free to type in this link or scan this Bluetooth, this QR code, and it'll take you right there, and fill out the survey. That's the appropriate survey, and help add to our database in terms of how you feel about engagement, and help improve the quality of care that we provide here at the MUHC. So I just want to mention patient and family-centered care is more than just buzzwords. There's actual meaning. It does impact outcomes. This area is kind of accelerating in research, and it's something that hopefully in the future will be even a more ingrained part of our care. So I leave these questions with you, and I'm sure, hopefully, you have some other questions as well. How do you engage families in care? What are some of the challenges you encounter? Have you experienced any benefits? Do you think it can prevent healthcare provider burnout? And I open up the floor. Thank you for your time.
Thank you so much. Thank you, Dr. Goldfarb. Thank you, Michael. Really interesting presentation. Congratulations on all the work you've done advancing this field. And I would say that anyone who is in any kind of clinical practice on this presentation, has learned something from your presentation. I'm sure of that. I'm certain of that. We have a lot of questions actually, so we'll start quickly with some of the questions. Do you have any data on attitudes of staff towards patients who do and do not have active family member engagement? I guess the question is, there's people who really have zero family member. You're there for you round on them 3-4 days in a row, and those no family members are around. What does the data look like, and is the care given a little bit differently for these patients?
That's a very good question. I don't think there's any specific studies looking at that. I mean, just anecdotally, there's often from the nurses or even some physicians, sometimes there may be hostility towards family members or who may be overbearing or too engaged in care or too want to be too involved in care. I don't know of any studies or any qualitative studies that look at this specific question. I think it's a very good question. I think it's our role when the family members are not involved to first of all, often we actively look out for family members. Sometimes they're unaware that their family members in the hospital in rare cases, but sometimes family members, some patients have zero support. But I think a lot of times there can be virtual support. So I think that, as I said, there's a need to reach out to family members and try. Often that they can't come because they're in a different city or they have their own health issues. But when there really is no family member, I think there's a role for the healthcare providers to be even stronger advocates for that patient. But there's no evidence on that. It's a very good question.
So there no data, because to follow up on medical or nursing errors, are there less if there are families involved? Is there hard data that shows that?
That's another great question. I'm writing all these points down to look up, but as far as I know, there's no data that having family members present changes the errors. I can point out when family members are involved, often the errors are more apparent and they often get pointed out. So I would imagine having family members involved most likely causes a bias towards finding more medical errors. Because as you know, as many clinicians know, family members often point out that an error was made and then that's corrected. So I think the bias is just from data collection is going to show the opposite. But as far as I know, I can look this up. I don't know the answer to that question.
A comment from Wendy Chu: as a geriatrician and on the family member side of the fence multiple times, it's wonderful to hear family involvement is being studied and promoted. Are family members screened for caregiver burnout before engaging them in participating in care?
In terms of the studies that are in the literature, the answer is no. That's not done. In terms of the studies that I have underway, yes, but it's more of an issue in the ambulatory setting than in the in-hospital setting. In hospital setting, they're not as engaged as in the outpatient setting sometimes. So I think there's a need really more in the ambulatory setting, and we are putting kind of caregiver burnout questionnaires to families members in the heart failure clinic. There's a study that we're trying to get underway. But the answer to your question is generally not done. But that's quite important, because whether the caregiver is at risk for burnout or not, or is currently burned out, definitely will affect how they participate in care. And that's a great point. That's something that should be done, but is generally not looked at.
So you mentioned heart failure. Is your program providing info on CHF to families before asking for engagement?
I'm not sure what I mean by providing info on heart failure. We're giving general education on what heart failure is and how to manage it. And I mean, there's so many different routes of looking. There's so many different ways of looking at engagement and care, and we have to really be simple in order to disentangle all these kind of complex interactions that are in place. I'll say like that. What I mean by that is we're trying to do one simple resolution, one simple intervention at a time, and seeing if that improves engagement. But even before we start that, looking at mostly, we need to measure engagement. Because right now, since we're not measuring engagement, you have what I've presented, which is interventions which improve an aspect of engagement and looking at outcomes. But I think we actually have to see, are we actually improving what we purport to improve, which is the actual engagement measure. So yes, it's important to provide information. It's important to assess whether the family member is engaging or not. Usually family members that agree to participate in the studies that I've done so far are family members probably not at risk for engagement because they want to be more involved. So there is a bit of a selection bias in those who are participating. But there is a need to inform family members, provide them education, and assess whether they're at risk for burnout before engaging them in care, for sure.
Is teaching CPR part of family engagement, empowerment of level of care A/B cardiac patients? Do you consider that part of family engagement when you get people involved in learning CPR?
As an ambulatory care, for sure. In hospital care, it won't make much of a difference because you have other people standing by that can do it. But it's something that has not been classically called family engagement or empowerment, but it definitely is. I mean, who is the person most likely to save the cardiac patient's life in heart failure, and who has heart problems? It's the family member. They're the bystander, and we know that bystander initiated CPR is associated with much better outcomes. So that can definitely not only save lives, but it can definitely empower the family member that they can do something. And one of the areas that touches on is that there's a need for family members to feel that it's one of the levels of activation is there's a need for family members to feel that they're resilient and that they can deal with emergencies that arise. So if a family member says, well, you know, I can give out the medications, but if an emergency happens, I don't know who to contact. I don't know what to do. I don't know where to call. That it really affects their ability to engage in care. So if you provide them the tools and the knowledge, which is the education that Dr. Morais mentioned, as well as teaching CPR, which is the education, and they can then be active in case of needed, then definitely that will improve family engagement, empowerment for sure.
Just another comment here from David Rosenblatt saying that several decades ago, the late Richard Goldblum gave a pediatric grand rounds on involvement of patients in direct care. Do you know if that's been, that experience was published? This was in Halifax. Do you know about that?
The truth is, I don't know a lot about pediatrics. Pediatric family involvement is actually a very different kettle of fish, as they say, because it has to do with parents, mostly with their children. And so there's the actual literature is much more developed in pediatric care, especially pediatric ICU, because family members are actually extremely instrumental in helping with care, both in hospital, with transition of care, and then between care visits. So the pediatric literature is extremely different, and I have not delved in other than looking at a few specific aspects. So I don't know if that was published. Sorry.
Just a quick comment here from Stephen Grover. Great talk, Michael. He's talking about cardiac rehab, and at the CHIP program, they've been inviting family members to join for years and shown that family support reduces dropouts. And he says they have 1,500 veterans who are participating in online health promotion, and wants to share that data with you. So I'll invite you to read that yourself. There's other really nice comments, Michael, from people really enjoying your lecture and having learned a lot from your lecture. So I'll invite you to read that in the chat. We're running a low on time, but I want to make sure that we have that people know where to go, because there's a lot of people, medical people, on this presentation. And if a award, let's say one of the clinical teaching units decides that they want to, to assess patient involvement and improve upon that on their ward, where would you point them to? Do we point them to you or your team, or where would you suggest they start?
Yeah. So I'm working with, our team is working with the quality improvement team at the MUHC. So there's a whole department for quality improvement. I always forget their name because it kind of changes. There's a quality and safety, patient experience, maybe the patient experience. They're excellent. And they really can help provide all the resources. They help provide us with a patient and family partner. They help us with our questionnaire to make sure that we're capturing the right aspects of care, that the wording is appropriate, and they help with the implementation and the follow through as well. So I believe it's the patient experience department, but I'm happy if anyone wants to get in contact with me, and I can either help them or point them to the right direction. And like I said, I think the goal is to implement small things, not to try to overhaul the system. Implement kind of one small change and see how it works, because I think that will help change the culture, and then we'll make larger impacts on the after implementing a few smaller scale projects.
Fantastic. So we're coming up on the hour, Michael. Thank you so much. Really exciting work. A very, very interesting presentation. And congratulations really on all the work you've done advancing this field. Really, really, really well done. So I'll invite you to read the comments in the chat, Michael, before you shut down. Thanks everyone for joining us, and have a wonderful afternoon.
Thank you.